Welcome to this series where I'll be discussing the 2026 ACC AHA guideline on the management of dyslipidemia. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in easy endo prep designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.easendoprep.com to enroll in the full course or start your free trial. Today, we will review lipoprotein A, ApoB, and monitoring strategies with emphasis on cardiovascular risk stratification and clinical application. Measurement of lipoprotein A is recommended in all adults at least once for cardiovascular risk assessment. This is a one-time test in most individuals because lipoprotein A is genetically determined and remains relatively stable over time. Levels are largely set by genetics, with minimal influence from lifestyle, which is why repeat testing is usually not necessary unless there is a major clinical change. In individuals with familial hypercholesterolemia, premature cardiovascular disease, or elevated lipoprotein A, cascade testing of first-degree relatives is recommended. This allows identification of additional high-risk individuals within the family and helps uncover inherited risk early. When measuring lipoprotein A, it is important to use laboratories that employ assays which are not affected by apolipoprotein A isoform variation and are traceable to official reference standard materials. This allows for more accurate measurement of lipoprotein A and better assessment of cardiovascular risk. Now let's move to how lipoprotein A levels translate into cardiovascular risk. Lipoprotein A should be less than 30 milligrams per deciliter. At 50, the risk is approximately 1.5 times higher. At 100, the risk is about 2 times higher. And at 150, the risk is about 3 times higher. Also remember that lipoprotein A contributes not only to atherosclerosis but also to thrombosis and aortic valve disease, particularly calcific aortic stenosis. Now shifting to ApoB. ApoB reflects the total number of atherogenic particles, including LDL, VLDL, IDL, and remnant particles. Each atherogenic particle carries one ApoB molecule, so ApoB is essentially a particle count and often correlates more closely with cardiovascular risk than cholesterol content alone. In adults already on lipid-lowering therapy, particularly those with cardiovascular disease, cardio-kidney metabolic syndrome, type 2 diabetes, or elevated triglycerides, measuring ApoB is reasonable. This helps guide further treatment intensification after LDL and non-HDL targets are achieved, especially in patients where discordance exists. Now monitoring and follow-up. In individuals on lipid-lowering therapy, a lipid profile should be checked 4 to 12 weeks after starting therapy or after a dose adjustment. After that, monitoring should occur every 6 to 12 months. This allows assessment of treatment efficacy, adherence, and the need for therapy adjustment. In higher-risk individuals, more frequent monitoring may be appropriate. Lastly, let's talk about the PREVENT equations. In adults aged 30 to 79 years without cardiovascular disease or subclinical atherosclerosis, and with an LDL between 70 and 189 milligrams per deciliter, the PREVENT equation should be used to estimate 10-year cardiovascular risk. Risk is then categorized as low risk, less than 3%, borderline risk, 3% to less than 5%, intermediate risk, 5% to less than 10%, or high risk, greater than or equal to 10%. The PREVENT equations are based on a large, contemporary, and representative sample of United States adults, with about 3.3 million individuals used for derivation and a similar number for external validation. They allow risk prediction beginning at age 30 and extending through age 79. They use sex-specific equations, and race or ethnicity is not included because it did not add predictive value. These equations also account for competing risk of non-cardiovascular death. They include a base model using commonly available clinical variables including age, sex, blood pressure, total cholesterol, HDL, diabetes status, tobacco use, kidney function, statin use, and antihypertensive medication use, with body mass index included for heart failure prediction. They also offer optional models that can include glycemic status, assessment of proteinuria and chronic kidney disease, and zip code to account for social deprivation and social determinants of cardiovascular risk. These are not required, but can improve risk prediction when available. They provide both 10-year and 30-year risk estimates. They estimate risk for atherosclerotic cardiovascular disease, heart failure, and total cardiovascular disease, which includes both atherosclerotic cardiovascular disease and heart failure. They show similar ability to discriminate risk compared to the pooled cohort equations. They also provide more accurate risk estimates overall and across demographic groups, with risk estimates generally about 40 to 50% lower than those from the pooled cohort equations for the same risk profile. Let's briefly discuss the rationale for updated 10-year risk thresholds when using the PREVENT cardiovascular risk equations for lipid-lowering therapy. Lipid-lowering therapy is considered for patients with borderline risk, 3 to less than 5%, intermediate risk, 5 to less than 10%, and high risk, greater than or equal to 10% predicted 10-year risk. Risk estimates from the PREVENT equations are approximately 40 to 50% lower than those from older pooled cohort equations. Despite this, a similar number of adults in the United States would be recommended to consider statin therapy when using a threshold of 5% or higher with pooled cohort equations, or 3% or higher. Clinical trial data show that statin therapy provides a net benefit, meaning benefit outweighs potential harm when the 10-year event risk is 3% or higher in primary prevention populations. Let's end with numbers to remember. Lipoprotein A should be less than 30 milligrams per deciliter. For risk categories using PREVENT, low risk is less than 3%, borderline risk is 3 to less than 5%, intermediate risk is 5 to less than 10%, high risk is greater than or equal to 10%, and for treatment threshold, think 3%. At 3% or higher 10-year risk, statin therapy shows net benefit. This was another bite-sized episode of Endo in a Bite. Remember to visit www.ezendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. Let's get through this document one bite at a time.